And through the years, the practice of medicine is becoming more complex because of an increasing number of patients who are immunocompromised, those who are undergoing chemotherapy, transplantation, and even those who travel to countries where diseases are vaccine preventable. And before going to surgery, they are also beset by this question: when can I start doing the surgery on my patient? And with this afternoon, the topic will be on ID clearances, because as ID specialists, we are getting more referrals now to make or give clearance to such kind of patients, which have I stated earlier. And to tackle this topic, ID clearance in the Belvedere, perspectives and pearls, I will now call Dr. Claire Coronel, my co-chair, to introduce our speaker.
Good afternoon. Our speaker for our second plenary session this afternoon is the current president of the Philippine Society for Microbiology and Infectious Diseases. He is also the treasurer for the Philippine College of Physicians. He is the chair for the Department of Medicine, University of the East, Ramon Magsaysay Memorial Medical Center. He is the assistant head for training and research and the chief of the Section of Infectious Diseases at the Department of Medicine, St. Luke's Medical Center in BGC. And he's also a medical specialist too, and head of the Section of Infectious Diseases, Department of Medicine at Dr. Jose Reyes Memorial Medical Center. He's one of my professors back in medical school in UST, and he is also one of my mentors before in fellowship training in infectious diseases. So let us all give a warm hand of applause to Dr. Mario M. Panaligan.
Thanks, Claire. Yeah. Okay. I'm setting the timer because I might go over time. This topic is actually a topic that I've been proposing since 3 years ago. Walang gustong kumuha. I don't know, maybe it's something easy, but when I was actually preparing for this, it's not actually. It's very broad. And that's why the title is actually very good, no? In the Belvedere, perspectives, and pearls. Still not. Okay. So as I've said, no, it's not an easy topic. Of course, I tried searching for a presentation, even YouTube, and this is what I actually found. Nothing that will actually demonstrate what we actually want to hear and talk about. No? And so I'll go on with the definitions. No? First, of course, infectious diseases are known to be disorders caused by organisms, no? Bacteria, virus, fungi, parasite. Some can be passed on from person to person, or some are transmitted from animals, and others are actually acquired by ingesting contaminated food or water. Next, please. Now, clearance is the official authorization for something to proceed or take place. Next. Now, Belvedere, a summer house or open-sided gallery, typically at rooftop level, commanding a fine view. Perspectives are points of view. And then pearls are, of course, things or humans that are of great worth. So when you talk ID clearance in the Belvedere, is actually looking at it at a broader perspective. So I'll be discussing, of course, when we actually need clearance when we talk about patients or individuals who get sick. So for the framework, what are the indications? When is it truly needed? And how do we do it? So let me start with this one, which I lifted, of course, from the internet. How pathogens make you sick or make us sick. Infection does not necessarily lead to disease. So we know that we can carry many organisms, but will not manifest any sign or symptom. And in response to infection, your immune system springs into action, and therefore we will manifest, depending, of course, on how we behave, depending, of course, on our susceptibility to that particular pathogen, or even commensal if we are actually immunocompromised. So this is a very familiar figure that will show you the chain of infection. You can see, of course, the interaction between the causative agent, the reservoir, which can actually be humans, animals, even mosquitoes, ticks, the soil, the water, inanimate objects like food. Of course, the portal of exit, the gastrointestinal tract, urogenital tract, upper respiratory tract, blood, even the skin, the mucous membrane, the method of transmission. Of course, we know that's either direct or indirect contact, and certainly we can also get these organisms through fomites, water, body fluids. And the portal of entry, of course, usually the skin, the mucous membrane, same as the portal of exit. And then the host, who can actually get the disease or the pathogen, and later on would manifest with an illness. So moving to healthcare intervention, certainly when we encounter a patient who has an infection, we certainly would want to recognize that particular infection, whether it actually needs an antibiotic or not. Remember that most of the time, ito favorite ko sinasabi, hindi na lahat ng infection kailangan bigyan ng antibiotic because many are actually viral infections. But for us, we must be able to recognize if it's really bacterial or something that needs antimicrobial therapy. And usually, we should not be late and we immediately start an antibiotic, primarily because we don't want our patients to have complications, and therefore we start an empiric regimen. And then before that, of course, we request for microbiologic examinations so that later on we can be guided with the culture results, and we will have a definitive form of antibiotic treatment. But there are some instances that we give prophylactic antibiotic, primarily because we don't want our patient to suffer infection. Usually we do this when there's an elective surgery or the patient is immunocompromised. We would like to give preemptive treatment so that they won't have or they won't develop an infection. And an additional intervention is, of course, immunization, because we know that vaccines are quite protective, and therefore we give this particularly to those who are at risk of developing this type of infections that are vaccine preventable. And most important, of course, infection control. Number one, the most cost-effective measure to prevent infection is certainly hand hygiene. And other than that, of course, there are lots of precautionary measures that we should remember, particularly in terms of the means of transmission, and therefore we observe standard precautions. And then if we are able to identify the infection, whether it's airborne, droplet, or contact, then we add the transmissions-based precautions. So this problem was brought up earlier by Dr. Chua, and certainly we are encountering it now, and that's the reason why we're having antimicrobial stewardship program. And antimicrobial resistance occurs when microorganisms change when they are exposed to antimicrobial drugs. Siyempre, madalas ginagamit antibiotics, and therefore there's misuse, overuse, and sometimes, of course, our patients would not respond. Primarily, we are not giving the correct antibiotic, and that bug will become resistant later on, and these patients develop another infection, and that can actually be a more severe or difficult to treat infection. And certainly, antimicrobials become ineffective, infections persist, and the chances of this organism spreading to others is there, particularly if you don't actually observe proper infection control measures. So, certainly, antimicrobial resistance is accelerated by misuse and overuse of antimicrobial agents, and certainly higher rates of resistance have been found or have been observed in healthcare-associated infections compared to community-acquired infections. And these are always associated with worse outcomes and higher costs. And I think, again, this was brought up earlier, there's limited antibiotic in the pipeline, and certainly we might run out of options soon. So when does an individual need an ID clearance? So usually, we see patients who are sick, and they will actually ask from us medical clearance for them to get back to work. Because prior to surgery, during chemotherapy, immunosuppressive therapy, and before travel, entry to protected or endemic areas. So moving to fitness to work, certainly we need to know the kind of infection, and it matters to observe and advise infection control. We have to tell them, advise them the means of transmission. Halimbawa, yung hepatitis A, do we know that that actually virus can still be excreted out in the feces until 4 to 5 months, even after the patient has gotten sick? 4 to 5 months, and therefore we need to advise these patients that they need to be very careful when we are actually moving their bowels, and they really have to wash their hands. And of course, we must also explain to the generation contagiousness. For example, when talk about chickenpox, hindi nyo naman tatakutin niya pagka meron na silang langib or scabs, nakakahawa pa rin sila. There's actually a time that they can actually mingle with others because they're no longer infectious. So the type of work is very important. So it's also very crucial that when we encounter food handlers, again going back to hepatitis A or those patients are handling or carrying salmonella, and therefore they have to be advised and treated, and later on monitored if they are still carrying this organism, primarily because they can actually transfer this to the food that they're actually preparing, and therefore that can cause problems or outbreaks later on. So moving to before surgery, usually elective surgery in adult healthy patients. In emergency surgery, there are guidelines that we can follow, of course, and we also give clearance for surgery among cancer patients or those who are about to undergo transplantation. So remember, of course, the different classification of wound scar, whether it's clean wounds, clean contaminated, contaminated, and dirty contaminated, and certainly there are guidelines, as I've said, depending on the type of wound scar. Certainly, we need to follow all these recommendations collectively, not only one, but collectively, so that we can minimize the possibility of SSI. So I'm just running this because these are too many, but I have to emphasize, of course, when we talk about surgical site infection, we also need to remember when and how to give the antibiotic treatment. And we also have to assess our patient whether they have these risk factors that would predispose them to develop specific organisms that are not usually found in SSI. For example, if they have diabetes mellitus, or if they've been taking antibiotic previously for longer periods, and certainly we have to think of multi-drug resistant organisms. And of course, we talk about infections during surgery. Siyempre, dapat i-clear natin because one of the forms of management is source control. If it's actually need to be debrided or drained, definitely we can clear them immediately for as long as we give the appropriate empiric antibiotic. Just make sure to request for gram stain and culture insensitivity, and then provide supportive management. Number one, of course, when we talk about sepsis, siyempre kailangan adequate supportive management. Now, moving to surgery in cancer patients, certainly these are individuals who have an increased risk of infection, particularly those who are myelosuppressed due to chemotherapy or hematologic malignancy. And as much as possible, the surgery should be postponed in neutropenic patients. Ibang usapan lang, kung emergency, then you just have to be aggressive and treat accordingly and make sure that you work up these patients so that you'll be properly guided later on if you're able to get a reliable culture and sensitivity results. Oops, sorry. So pre-transplant evaluation, of course, number one part is educate them as to what will happen to them when they undergo the transplantation, and later on they will be immunosuppressed primarily because of the anti-rejection drugs that they have to take. Speaking from experience, I know what would happen after the transplant, primarily because we can actually develop infections because of the many drugs that we have to take that will render us immunosuppressed, and therefore we can develop severe infections later on. And then if there is a suspicion of an active infection, it's better really to investigate it so that you will be able to know and isolate, of course, the bug for as long as you know what particular site you're dealing with. And then it's also quite important that before transplantation, you screen also for latent infection and even colonization. For example, you have to determine whether the patient is a carrier, or if the patient has latent TB or even the other viral infections that can pose problems later on during post-transplantation. And of course, pre-transplant immunization also advocated, this can somehow protect later on these individuals. Bumabalik. So as I've said, immunization is actually advocated for organ transplant candidates. Now, remember that there are individuals who have altered competence, either primary or secondary. Usually primary is hereditary, secondary is usually acquired due to the illness. For example, if there's malignancy, leukemia, or even HIV, and of course in relation to the treatment because they're receiving immunosuppressive treatment. Now, post-transplantation is quite important for us, again, to advise them in terms of the risks that they will still have, and therefore they can develop this type of infection primarily related to the intervention that they're actually receiving. And when we talk about cancer, usually if it's solid tumor, it's also related, of course, to the size, the location, and we know that, for example, if there's lung cancer, they're more prone to develop pneumonia. Of course, if they have liver cancer, they're more prone to develop biliary tract infection. And of course, aside from that, because of the chemotherapy, they'll be rendered immunosuppressed, and therefore they are prone to opportunistic infections. So moving to gastrointestinal rheumatologic disorders, certainly there are lots of conditions now that can be given monoclonal antibodies, anti-tumor necrosis factor alpha, and these are immunosuppressive agents that can render these individuals immunosuppressed. And part of our job is to assess them, ask them, get a good history, do a thorough physical examination, and request for some laboratory examinations later on that will guide you in terms of how you're going to manage these patients when they develop an infection. So these are the different drugs that we usually encounter when they refer their patients to us, and usually they are related, of course, to the effect on the immune system depending on the drug. And I mentioned about anti-tumor necrosis factor alpha, which is a favorite drug now. They can actually cause reactivation of tuberculosis. So I would like to acknowledge, of course, Dr. Tang and Dr. Ben Salido, who actually gave their paper to me. It's actually a retrospective study on patients referred to ID for evaluation and clearance prior to immunosuppressive therapy. and they were able to get 83 inpatients, no? And we were able to look at the underlying medical conditions, the most common of whom are solid tumor malignancy, followed by hematologic malignancy, and then rheumatologic disorders. The most frequent type of infection, why they were actually referred to ID, is pneumonia. And 71 or 85% got cleared, 63 underwent immunosuppression. Now the delays in giving clearance is of course due to the active infection, and Dr. Bensilida actually worked them up and tried of course to know and give the appropriate antibiotic before clearing them. And only 11 died, or just 13%, with 4 developing pneumonia after immunosuppression. So they concluded that the way they actually cleared these patients are somehow reasonable. However, up to this time, there's still no guidelines in the Philippines or even outside that would guide clinicians on when we can actually clear patients for immunosuppressive treatment. Now moving to febrile neutropenia, low risk, oral antibiotics pa din, even with the latest guidelines, comoxiclav plus ciprofloxacin. For inpatients, we still don't have new guidelines, still monotherapy versus Pseudomonas aeruginosa. What I'm trying to tell you is, of course, even if we are dealing with immunosuppressed patients, we also need to address active infections, especially if they develop them. Remember that these are immunosuppressed, and therefore we need to manage them accordingly, because these patients are also the main source of organisms that can cause infections to other susceptible individuals. So, nag-move ng fast. Anyway, you just have to remember that even during chemotherapy and immunosuppressive therapy, there are prophylactic antibiotics, antifungals, antivirals that you can also give, provided that there are, of course, risk factors. And certainly, you just have to know, of course, the different immunosuppressive drugs that they're receiving and the link to what immune problem that they would develop and what organisms are more frequently associated with these problems. And certainly, when we talk about transplantations, most of the time we give them, of course, prophylactic antiviral like valacyclovir, and then prophylactic antibiotic for pneumocystis because of the steroids. So they will receive cotrimoxazole and even itraconazole to prevent fungal infection. Now moving to before travel, can you go back? Before travel, of course, they would also ask us in terms of what they're gonna do, but we also need to advise them, of course, on what they should remember, what they actually need to receive before going to areas that are known to be endemic for specific infections. And we also need to educate them in terms of what they need to do, especially, for example, if they develop diarrhea and they're elderly, they're actually allowed to take emergency antibiotic, and of course rehydration measures. And of course, they need to be assessed in terms of their comorbids, cardiovascular and even lungs, including deep venous thrombosis risk, and of course malignancy. And screening should be done, especially those, I've done this a lot of times, especially for nurses going to the States or even in Australia. They need to be screened for latent TB, and screening per se would require not only tuberculin skin test, but even TB IGRA, because these countries actually require them both, and Singapore actually requires TB culture and sensitivity before they accept them. Now they also need to be checked for serologic tests for specific viral infections, especially again for those individuals migrating, and also they need to be vaccinated. In fact, we need to sign a proof that they have received these vaccines. So immunization, usually, of course, recommended, particularly among individuals who would go to areas that are known to be endemic for specific infections, like those going to Sub-Sahara, they have to receive meningococcal vaccine, and then in the Philippines, they are actually required, travelers are actually required to receive rabies vaccine and Japanese encephalitis vaccines. Okay, so depending on the area where you will go, you actually need to consult and you need to give clearance before they are actually allowed, no, to go to those countries. No? Of course, preventive medicines might be important, especially if they're going to go to malaria endemic areas. No? Chemoprophylactic drugs are quite important. You also need to know how to advise them on when and how they should actually take these chemoprophylactic drugs. For example, doxycycline can be taken once a day, and they can actually start it even 2 days before departure. Unlike when you give mefloquine, it has to be started 1 to 2 weeks before, and it taken once a week, and then have to be continued 4 weeks after leaving the area. So dapat alam din natin yun, so that everything has to be addressed. Now we'll talk about giving clearances to patients or those individuals traveling abroad. And then of course, post-travel, siyempre, pag nilagnat yan, o nagkasakit, very crucial for us, to us, the history, no, on where they actually went, what did they eat, and how they, and what kind of exposure did they have. So importante, alam niyo, napunta ba sila sa gubat, napunta ba nag-forest ba sila ng gabi, baka may malaria o namalaria sila. Very crucial is to really ask about exposure history. And be familiar with the alarm signs, was fever, severe vomiting, hemorrhage, seizures, hypotension, altered sensorium, and respiratory distress. And remember that empirical therapy may be necessary, especially if the patient is already presenting with the alarm signs and symptoms. Now, it's quite difficult really to avoid talking about the special ID problems, primarily because as ID specialists or doctors, we need, of course, to address other infections that can occur in relation, of course, to the infections that are becoming common, or the patient is actually having, there are classes of infections, like outbreaks. Of course, if infections is happening in the workplace, in the school, of course, infections in pregnancy, and even infections in HIV. So remember, healthcare-associated infections are those infections that can occur while a patient is receiving care in a healthcare setting, or even after discharge, and can result in prolonged hospital stay and even higher mortality, primarily because increased antimicrobial resistance. And of course, we must be able to advise them on how to prevent healthcare-associated infections, going back to infection control. Remember the standard and transmission-based precautions, environmental sanitation, and antimicrobial stewardship and immunization. Of course, we will not forget the 2003 SARS epidemic. This has happened, of course, long time ago, but this can actually again recur, or even the other viruses that can become epidemic. Of course, still MERS-CoV is still there. And of course, we're still waiting, of course, the H3N2 or the avian flu that can actually mutate. And that can happen. It can cause multiple problems, not only in other areas, but even the Philippines, because of the ease of travel. And we need to know, of course, how to handle outbreaks. Of course, we need to know or learn how to investigate if there's really an outbreak, and also observe proper measures on how to contain them. Of course, know the quarantine procedures, how to isolate these patients, and of course, vector control if it's related to an arthropod. Now, moving to infections in the workplace, the main goal is to prevent transfer of pathogen from one person to another. And just remember, you have to assume everyone is as potentially infectious. And certainly, we need to, again, observe the basic infection control procedures. Number one, hand hygiene. Infection in schools, fast spread because of ease and transmission. Understanding how allows easy ways to control. Again, basic infection control measures. Makakatulong talaga, hand hygiene and clean environment. Infections in pregnancy, all of us know the TORCH, Toxoplasma, syphilis, which under O, rubella, cytomegalovirus, herpes simplex, in the Philippines, hepatitis B, and the emerging problem, which is HIV. And let me show you the current, the latest data on HIV. We can see that the mother-to-child transmission is currently present, and I'm happy to announce that middle of next year, PSMID is collaborating with PIDSP, a Pediatric Infectious Disease Society of the Philippines, as well as PIDSOG of Philippine Infectious Disease Society of OBGYN for an HIV summit to target or address this particular problem in the Philippines. So right now, we treat HIV early. Treat all, following, of course, the WHO guidelines, based from the Administrative Order 2018-0024. And we also give ARV prophylaxis as needed, particularly, of course, for infants born from infected mother. Certainly, we treat opportunistic infections, and we give secondary prophylaxis as necessary. This is the list of the prevention strategies, of course, education, counseling, testing, condoms and lubes, needle and syringe program, prevention of mother-to-child transmission, post-exposure prophylaxis, and, of course, pre-exposure prophylaxis. I just had to include this, of course, a novel diagnostics, which can actually be helpful soon, because definitely this can help us know the etiologic agent causing the infection. And this, of course, available in bigger hospitals now, and certainly can be helpful. Without even growing the organism, we can already identify the organism. Somehow, we can address the problem immediately, and therefore we can also cure and provide cure rather, and later on provide clearance for our patients, somehow control the infection, especially if there's already clusters of infection. Things to remember: be updated and know the current problems, utilize clinical practice guidelines, be familiar with clinical pathways, practice infection control, and get protected. So, can we actually show this video? Can you click that small letters there, down on the right? No. Can you go back? Paki-push yung sa baba. I want to show you this video kasi naghahanap na ako ng video. I saw this one that can help us fight the spread of infectious diseases. Can you? Can you click small letters on the right side, right? Can you enlarge, please? Walang sound. If it's not possible, let's go to the summary.
In school today, I know how to fight. Let me teach you. F-I-G-H-T. Fight the spread of infectious disease. Wash your hands frequently. Kill the germs that you can't see. Immunize. Get your flu shot, you'll be fine. Go to the doctor if you're sick.
Stay at home to rest and sleep.
Tissues and masks are a must, cause fighting the spread is everyone's task. F-I-G-H-T, let's F-I-G-H-T, let's go. F-I-G-H-T, let's F-I-G-H-T, alright. F-I-G-H-T, F-I-G-H-T.
Okay, if they were able to come out with a dance number for the hand hygiene, maybe this can also help, if we actually dance and sing, this F-I-G-H-T, to spread the spread of infectious diseases. Summary slide, please. So giving ID clearance entails familiarity on how the process develops. Careful assessment utilizing good history and physical examination along with suitable laboratory tools is necessary. Awareness of latest information and updated guidelines is valuable so that we can, of course, manage our patients accordingly rather than just giving these patients clearance that they actually need. No? Be on your guard, stand firm in the faith. No? From 1 Corinthians chapter 16, verse 13. Yeah, thank you very much. Yeah.
Thank you, Dr. Panaligan. And now on, may I call on the chair of our